we're from the emergency department at Regions, and our team was the painkiller ERs. And most of our team is sitting up here in the rear in front of us. We really appreciate them being here. And a special thank you to Mary Sakura, who is our community advisor, who couldn't be here for the afternoon, but she was really instrumental in helping our team, and we learned a lot just from having her being a member of our team. So our aim statement was that we will reduce the disparities in the percentage of patients who receive analgesia and improve time to analgesia for extremity fractures across specific neighborhoods in St. Paul by 10% by 12/31/2011. So there's a lot in that aim statement, and I wanted to talk a little bit about why we decided on that aim statement and kind of what went into that. So as Beth mentioned before, we know that there are disparities when we look at the literature regarding time to analgesia. So the time it takes a patient from the minute they arrive in an emergency department until the time they actually get pain medication. It's well documented in literature that there are disparities in emergency medicine with how we deliver pain medication to patients, specifically regarding the time that it takes them to receive those pain medications. So that's why we really decided to focus in on analgesia and pain medication as it related to extremity fractures, which is what most of that data is based on when you look at the literature. I'll talk a little bit more in a second about why we decided to focus more on the percentage of patients, because actually our data was a little bit interesting when we first got our first round of data back. We really wanted to tie this project into the communities that surround St. Paul, so we decided to focus on patients from the neighborhoods surrounding St. Paul. So all of our data is from patients with a St. Paul zip code, so patients who live right around the hospital that we work in. So initially when we looked at the data, we expected that we would see a disparity in the time it took patients to receive analgesia. The two most numerous, most populous groups that we have are patients who self-identify as white and self-identify as African American, so that's why I have this up here. But actually we found that it took whites longer to receive medication than it took African Americans. So we then decided to switch our focus and look at the percentages of patients who receive pain medication. This is a graph that just shows the percentage of patients who receive pain medication, and it's sorted by self-identified race. So the two most numerous groups that we had in our initial data set were whites, which had about 250 patients in that group, and African Americans that had about 150. Everybody else had less than 50, so that's why we really decided to focus on those two groups. But as you can see, there's definitely a disparity between the percentage of patients who receive pain medication, with whites it was almost 80%, and African Americans who had in the upper 60s. So this is really where our focus became, was looking at the percentage of patients who receive pain medication. Sorry, I have a cold, so excuse my voice a little bit. So our primary intervention was to use and kind of make better use of Code Red. We have a lot of codes in the emergency department. Code Blue is a medical code. Code Gray is a potential stroke code. And Code Red was already in place as a way for nursing staff or any other staff to communicate the need to have a provider in the room within a very short amount of time. We'd already started using Code Red for pain control to help further communicate that need for anyone in the ER who the initial staff evaluating the patient felt that they needed very timely administration of pain medication. They needed someone to come in quick to make sure we could get those orders going. So our initial intervention was to make a broader use of that Code Red for pain control and apply it specifically to patients who had a suspected extremity fracture and then appeared or reported to be in a significant amount of pain. So we could really improve that communication between department members and team members to ensure more accurate or more timely administration of analgesics. We learned a lot of interesting things as we went through this project, and so we had some secondary interventions that came up. One is that we really wanted to focus on education and discussion regarding asking patients about their self-identified race. We'll talk more about that in a slide or two. We also wanted to focus on the way that we ask patients about pain, and so we distributed to the departments some cards with the FACES pain scale on there, which is just very helpful for people with specific barriers, so age barriers, cultural barriers, language barriers, to try to get a better documentation, a better idea of what they perceive their pain level to be at. We also initiated a survey before and after distributing these pain scales to try to get some department feedback about whether they used the scale, whether they liked it, and how much they felt that helped them in the way that they asked patients about pain. So when we looked at our data pre and post intervention, so after we did our intervention, we did find that we were able to improve that disparity. This is a list of the odds ratios that we found. And basically, as a quick review, odds ratio is the way of comparing whether two events are equally likely to happen. So an odds ratio of greater than 1 means that it's more likely an event happens in one group as compared to another group. An odds ratio of less than 1 means that they're equally likely to happen. So we found that before we did our intervention, whites were were more likely than African Americans to receive pain medication, an odds ratio of 1.42. Whereas after the intervention, the odds ratio is below 1, which means they're equally likely to receive medication. And it was pretty similar whether we compared whites versus African Americans or whites versus all the other groups. You can look at this graph again. So the red is our after intervention data. And while those percentages are still just a little bit different, they're much, much closer together, especially, again, just focusing on the most populous groups that we had, which were the white versus the African American. Our secondary aim, one of the secondary aims that we had, was to improve the capture of self-identified race. Most of the data that we look at is based on how a patient identifies their race, how they identify themselves, and that's how this data comes about that we get. And we noticed in our first set of data that we actually only had about a 72.5% capture rate of self-identified race. So we really started to look at how can we improve that? What education can we do? We had a lot of help from different members of our clerk group. There was one in particular, Don Lalonde, who came to this meeting today. That we had a lot of people that really got interested and involved in this. We started doing some education with the clerks, along with some people from Health Partners, just to figure out how we can better ask patients about their race. This is another way that our community advisor, Mary, was very, very helpful in just helping us learn how to communicate this with our patients better. We've just started this, but we did notice in our second set of data that we already did have an improvement in the capture rate of how we captured that data. But there's a lot of work to do on this, and I think this is something that people in the group are really excited about. Additional results. We did use that survey that we mentioned earlier, asking providers about their feelings and their use of the FACES pain scale. More people responded that they use the card frequently. ERTs, who are emergency department technicians, who do most of our documenting and asking about pain scales, also report an increase in using the cards often. We asked providers about their view of Code Red for pain control, and the majority of respondents said that they liked it. The majority of nurses, who are probably the main people that use this communication tool, responded that they liked it, and 80% of nurses reported that Code Red helps them get pain medications in a timely manner. Over to Mary.
Sure. So, looking at building a culture of quality, we've seen this gaining momentum over the last number of years certainly at Health Partners, but within Regents Hospital. At Health Partners, we're grateful to have the work of the EBAN project sponsored, because we have a model to look forward to and to look back to as we move forward with other efforts. At Regents Hospital, we've been trying to integrate the equitable care work. We have a house-wide committee on equitable care, but then how to have our department, have it trickle down into our various departments. We've done perfect MI care and congestive heart failure care, comparing how we're treating patients across race. And in our emergency department, we have a really active emergency department quality committee. But one of the things we've not looked at so closely is equitable care in our quality efforts. So this gives us an opportunity moving forward to look at these parameters, to look at these dimensions of quality care and the work we're delivering and the quality efforts we have in the department. In our residency, over the last several years too, there's been a real emphasis on integrating quality into the work of the residency, and just have residents come on board to become leaders in their profession, incorporating concepts with quality care into their work. Our nurse group too is very interested in quality care. We have more nurses interested in and looking at some quality efforts in our department and getting involved in research activity as well. Some of the great work with this done effort really is we're just on the cusp of that work with the end of our project here. Just tomorrow, one of our physicians who was involved in the EBAN project, Bjorn Westgard, is presenting a topic on emergency medical care to the community at the Wellness Center, the Cultural Wellness Center in St. Paul. There are two wellness centers, one in Minneapolis and one in St. Paul. And tomorrow, Bjorn will be there inviting community members, and it's sponsored by the Wellness Center, but community members will come and meet our physician in their neighborhood to talk about their concerns about health care, and specifically emergency health care. One thing we want to be able to recognize the amount of time and effort that those at the Cultural Wellness Center really dedicated to Regents so that we could work on this EBAN effort. So this is our chance to give back. And we expect to have between 6 and 12 cultural wellness presentations throughout the year. Hope to have our physicians and residents, but also nurses, and even maybe have financial advisors be able to participate. It's really fun to get ideas by being here today. With end-of-life decision-making, we imagine that's been a real concern and topic of interest at the Cultural Wellness Center, is having people from different cultures talk about their understandings of do not resuscitate orders and so forth. So this might be another possibility for a discussion at the Wellness Center. And this is where you really start to see the synergy between our work and the work in the community, and what our advisor would like to see us bring to them. Relationships, we've had great opportunities. It's been really helpful to have interactions with the other EVAN groups and learn so much about what they're doing, get new ideas on how we can approach our efforts. But in our own department, for instance, that Dawn is here today, it's great to get clerks and techs, ERTs, emergency room technicians, engaged in quality efforts, because you find that they really want to do the best by patients regardless of race. They want to think they're treating everyone the same. It's good to give them feedback and data that suggests sometimes that we aren't providing the same care, and then they will work to meet the mark. But the clerks really stepped up, and Dawn, thank you for helping get the clerks engaged in this discussion. In forthcoming visits to the Wellness Center, social workers will be talking also. We'll have Maddie from the social work office talk about mental health care in the community too. We are developing a culture of improved communication with our large size of the department, our growing emergency department. We've had to find new ways to communicate. And so this Code Red pain control both was in alignment with previous ways of communicating with one another, but also is a timely way to be in touch with one another for patient care. More of a challenge to sustain may be monitoring continued progress, keeping in touch with the quality committee so that we can get our information and progress for forthcoming issues back to the department. Ingraining this work in our process involves continuous feedback to staff with results. That might be one shortcoming we have with our current group. We worked a lot on the data and maybe didn't get enough back to our department because they're interested, they're curious. They had their curiosity peaked when we first started. We were discussing equitable care. Do we really deliver care fairly across race? There was real active discussions at the huddles. Now we need to bring the information back to them. Fortunately, we can use those great boards that you all put together for us to take back to the department, we hope. Also, we have a forthcoming CMS core measure that involves timely pain, delivery of pain management for patients with extremity injuries, and this will dovetail nicely with the forthcoming measure, the work that we've already done. And then integrating measures of equitable care into our EMD processes, as we've already mentioned. The spread, this is some of the more exciting work, is so in our department, reporting data to staff, but also reporting the activity that we have out in the community with the Cultural Wellness Center is going to be key to keeping our staff aware that we're really working in the community too, and the community has a perception of us that we want to be aware of and continue to improve the way we interact and how we approach concerns. We have work to do with clerk education because one of the things we're discovering is that clerks are not consistently allowing patients to self-identify their own race. There may be some estimation of what people's race is, and we just really want our clerks to understand how important it is, how vital that our data is accurate, that patients are self-identifying race, and that no one's making that assumption for them. And they definitely will be engaged in that. They're interested already. So we'll continue to use Code Red pain control. Continue reporting results. We'll have a report out to our operations committee in the emergency department. And with the introduction CMS core measures, we'll talk about the groundwork we've already laid with these projects. And then we have the exciting work of being in the community, having more community involvement with ACMERI and those at the Cultural Wellness Center.